Hi there, Shane and Caitlin here, and welcome to Science on the Table,
the podcast that covers all things South African science, where we take the tough stuff and break it down into bite-sized bits so you don't have to.
That's right, from soup to nuts. So let's lay it all out on the table.
The views and opinions expressed in this podcast are those of the hosts and guests and do not necessarily reflect the views of any affiliated institutions or organizations. Science is always evolving, and some information may become outdated as new research emerges. Always consult primary sources or professionals for specific advice, as this podcast is for informational purposes only.
Today we have a midwife as a guest on the podcast. Her name is Sister Jenni Clarence, and she's going to tell us all about what this profession and her job entail and what she does on a daily basis, and also explain the ins and outs. Jenni, thank you very much for coming onto the podcast. It's really exciting to have you on. I'm definitely going to learn a whole lot. It's a topic I don't know much about. Jenni, can you please tell us what your qualifications are, where you're from, where you've obtained your qualifications, and maybe just a little bit of an overview of the journey that brought you to where you are today?
Hi, Shane and Caitlin. Thank you so much for inviting me to this forum. I'm really obviously very excited to talk about my profession. So I am an advanced midwife. I didn't start out as an advanced midwife, obviously. So I hold a BSc nursing degree from University of Wits, which I obtained in 1989. And then I went on to do my advanced midwifery and neonatology. It was then the Rand Afrikaans University. I did that in 1997. So in order to become a midwife, I had to go through the whole long process of first becoming a registered nurse. And then I did the subsidiary midwifery and psychiatry and community health. First of all, midwifery, I didn't find midwifery. Midwifery found me. So I originally started, once I'd had my children, I decided I needed to use my nursing degree, and I started off with antenatal classes. And then once I'd had my third baby, I needed to get out of the house a bit. So I went into the hospital setting. And we progressed from there.
I love that thought or that phrase that you used. I didn't find midwifery, midwifery found me. And I find that to be the case in most health professions. It is something I encourage the young people to really do some soul searching about before they go into healthcare, because it really is a calling. It's not something you do as a career choice for, purely money-driven reasons. If you don't have a passion, you don't survive. And I think you can attest to that. It has to be 100% a calling.
Absolutely, 100%. I was always going to be a nurse. Where the first day I walked into the midwifery ward to do my training, that was the day that I wanted to actually hightail it out of there, hit the high road and never come back, because I was 20 years old at the time and I found it absolutely terrifying. But as the further I tried to run away from it, the faster it followed me and caught up to me. And now I don't have an identity without being a midwife.
That's very interesting, Jenni. I think what also makes it probably so rewarding, having been found by this career path, is also that you work with people. And as Caitlin said, it's just one of those things or one of those professions where you can't just, I want to say, wing it and stick it out. You kind of have to in some sense, have to be born with it, the skills and the passion for a profession like this.
Absolutely, 100%. It's one of the professions where the burnout rate is extremely high. You have to be on the ball, on your A game all of the time, because you're not dealing with one life, you're dealing with two lives. And also there is so much litigation at the moment in the field of obstetrics. You can't afford to take your eye off the ball for a minute. So you either 150% dedicated or don't do it at all.
We are going to be getting into quite a few different aspects of this field in this episode, but I thought where we could start is with a few definitions. Now, the public might not be well aware of all of the acronyms and abbreviations that one would use. Can we talk about the word C-section and NVD and what they mean?
Right. So my area of expertise is an NVD. Now you get two definitions of an NVD and they're both entirely different. You get a normal vaginal delivery, which is what most people refer to. So that means the baby comes out the way it went in, via the vagina, through the pelvis. What we like to talk about is a natural vaginal birth, which is what midwives in private practice aim for. A C-section is an abbreviation for a cesarean section, and that is a surgical removal of the baby from the uterus via the abdomen. It's 100% a medical situation. More often than not, an emergency situation. Or let me rephrase that. It should be an emergency situation and not the method of birth of choice.
I think that suffices. Thanks, Jenny. So, because you're a midwife, I think we'll start with some of the basic questions. And the question I'd like to ask is, why do people generally make use of a midwife? If we just consider the times we live in, because I know just from friends and family here that, okay, the delivery date is this date because we're scheduled for a cesarean section here and a cesarean section there. So it's not something I hear about often. But obviously, I mean, this is your daily life. And it's standard practice for you, which might not be for, I want to say, the majority of the population or for the average Joe. Yeah, so if you can maybe just start with why people would want to make use of a midwife, if you just, I don't know, anecdotal evidence or just from your experience.
Shane, there are various, midwives have a place on the wire right through the spectrum. So it's pretty much cradle to grave care. So without knowing it, every mom that gives birth in a hospital, whether she's having a cesarean or a normal or natural vaginal delivery, actually comes in contact with a midwife. So let me explain to you what the degree that our job takes. So if you were ever vaccinated in a clinic, 99% sure that a midwife did your vaccination. They did your follow-ups in a clinic. When you fall pregnant, you would, if you choose to go the obstetrician route, there's normally a midwife that's operating in the obstetrician's rooms that does observation, general screening before the obstetrician gets to see you. If you give birth in a hospital ward, the person that looks after you, whether it's a normal delivery or a cesarean section, is the midwife. So the midwives run the labor ward. And then obviously in the position that I am, I'm in private practice. So I'm an independent practitioner and I've got a birthing center. And so I see the patients right from the beginning of pregnancy all the way through the labor and their children up until till they're having kids. That's how long I've been in practice. So without knowing it, most people have gone through the hands of a midwife.
So that tidbit of information shows you how few people are aware of the role and the presence of midwives. Everyone thinks it's quite a specialized thing, and you choose either between a doctor or a midwife, but you don't realize the midwife is actually always involved. So that's wonderful. Thank you for sharing that, Jenny. And now we would like to know, how do you handle the births on your own? Because if you are working in private practice, that means you're not working through an obstetrician. Is that correct?
No, I do have a backup obstetrician. According to the guidelines, so we work according to very strict guidelines that regulates our practice. So 100% the most important thing that you do when dealing with a pregnant mom is the screening of that mom. If she's going to have a home birth, we have to screen everything to make sure that she starts off as a low-risk patient and that she remains a low-risk patient throughout the pregnancy. Should something change, and it can quite easily change, we then refer to an obstetrician. The obstetrician is the specialist doctor that deals with a pregnant mom. If it's a transient problem, like an infection and the mom needs admission to hospital for treatment, or hypertension that resolves, the patient can, or the mom can come back to us as long as she remains low risk. If she is high risk, she gets referred to the obstetrician and they manage the birth from there. So we work in a multidisciplinary team. So I also work with specialist sonographers. If in the case of any abnormality that we find in the baby, we work with a fetal abnormality specialist who's even more qualified than an ordinary obstetrician. So as long as the mom remains low risk, she stays with me. Anything changing that, she moves along the feeding chain to the obstetrician.
And while we're on the topic, Jenny, can you quickly just give us the roles of the obstetrician then, for those of us who are a little bit confused about what the gynae/obstetrician will do in the role of the pregnancy and the birth?
Okay, so I'm talking from a bit of a bias now, and we actually had our sensitive midwifery symposium this week. The latest stats was actually from a study done in 2019. For every 100,000 women in South Africa, there is 0.62 obstetrician. And for every 10,000 pregnant moms in South Africa, there are 5.5 midwives.
Oh, wow.
Yeah, very scary. So none of that is sustainable. From my point of view, obstetricians should be doing complicated births and midwives should be doing low-risk births, be it in the hospital or at home.
Jenny, I just want to know, if you say you work in a close multidisciplinary team, what would the general procedure be? So you're in constant contact with, different healthcare professionals. And if, for example, a woman is deemed to be low risk and she stays with you or in your care, or with the ultimate goal of being treated by you, and also you handling the delivery, are there telltale signs of when you would refer this woman when she all of a sudden becomes higher risk? And is that generally an acceptable time frame, or is it like a very shaky or risky time frame? I'm not sure if I'm making sense.
I hear what you're asking. So things can go belly up very quickly in a pregnancy. There's a condition called preeclampsia, which basically means that the mum develops a very high blood pressure She develops protein in her urine. She develops low platelets, and they develop a liver dysfunction. That can happen at any time during the pregnancy. Midwives don't scare easily. If you've got a mom that's got signs of preeclampsia, that is an immediate, don't collect your 200 Rand, straight to hospital and under the care of an obstetrician. But the patients are seen by the gynae according to the guidelines, maternity guidelines. They're seen twice in the pregnancy as a routine. And then we've got other scans that we do at 12 weeks and 22 weeks. But generally, all the patients go through the gynae at 36 weeks. So she gives the go-ahead that this is a low-risk patient and there's a good chance that she'll deliver. But midwives assess the patient well-being. That's why it's such a fulfilling job being in private practice, because you have contact with the patient from the beginning all the way through to the postpartum period. So you get to know your patients and you can see if there are any deviations from the normal.
Yeah. I suppose the longer you have a pregnancy or a normal pregnancy or very few or no risks attached to that pregnancy, it also bodes well for the later stages of that pregnancy.
100%. And it all comes down to good education. That's where her role is integral in promoting a natural vaginal birth. So we educate right from the beginning: diets, lifestyle, stress factors. So and that really does play a huge role in giving the woman confidence to birth naturally, and also the tools that she needs to have a healthy, low-risk pregnancy.
That makes perfect sense. I never realized, and that's just purely because of my ignorance, but I never realized it was such a well-regulated profession and well-organized, as you've alluded to, the multidisciplinary team.
Oh, yes. We use physios as well, chiropractors, sonographers, obstetricians, you name it, psychologists sometimes. Socioeconomic situations, sometimes the mom needs extra counseling. We also deal with things like teenage pregnancies, rape victims. So, yeah, the midwife is pretty much in the forefield of managing the care of a mom. And that's why so many moms want to use midwives, because they get to know us, we get to know the mom, and by the time the labor happens, they know me, I know them, I know their ins and outs, I know their work situation, their partnership, stuff you wouldn't tell your mom, they tell me.
Yeah, I can imagine. I mean, if you walk such an intimate and personal journey with a mother-to-be, then you eventually just foster some sort of very special and close-knit relationship.
And also the dad-to-be. And in the case where the dad is missing in action, the grandmom or the sister, so it's a family affair.
It's really nice to hear about this. And I also actually want to know, while we're on the topic of like different professionals and multidisciplinary teams, I've also heard of something called a doula. Is that someone you also work with? What does such a person do, and what's the difference between that and a midwife?
Yes, so I have a doula working with me. A doula is, she also supports women, advocates for women during pregnancy, but there's no medical procedures. They may not make a diagnosis on a patient. So basically it's emotional, spiritual, physical support, massage, positioning. A lot of them are trained in hypnobirthing. So it's just it's an assistant to both the patient and to the midwife. Sometimes they advocate for us as well when we're sitting with a burnout situation. So yes, I work very closely with a doula. But a doula may not, well, we say may not, so many pieces of legislation have changed that moms have sometimes been driven into free birthing, and then they get the help of a doula just as the extra support. But it's not strictly the way that it should go, because things can go belly up.
For anyone interested in having a baby, please do consult your professionals before you go through any of these processes. Consult your professionals, make sure that you're well looked after medically. We understand the need for natural procedures and so forth, but please do not try and attempt this on your own. Make sure you're consulting your professionals. So Jenny, while we're on the topic, can we please discuss the process of the natural vaginal delivery? So what we'd like to know more or less is how the procedure would go. Is there any equipment involved? And yeah, break it down for us, for our listeners, please.
Right. As I said earlier, we work according to a strict set of maternal guidelines. Every midwife has their own style. I like to refer to it as the art and the science of midwifery. So I do use a cardiotocograph machine. I know a lot of midwives aren't using it, but if you do have a situation where a birth suddenly goes not the way you're hoping, it's way easier to transfer a patient that's got a fetal distress if you have evidence on CTGs and you can explain scientifically to the receiving gynecologist what's happening. Other than the CTG, the most important tools that I use are my ears to hear what the mom's not saying, my sixth sense. A midwife never ever regrets having that gut feel, an extra set of eyes, and a pair of hands for support. I often say to my colleagues, a midwife just knows. So you get to feel, if you ever have a gut feeling about a patient, never ever ignore it. If you've got a super anxious mom, never ever ignore it. Something is brewing. And that's basically pretty much the tools you need, besides a bath and a birthing ball and massage techniques. And that's pretty much how I go with the flow.
In terms of other equipment that is available to midwives in hospital settings, for example, forceps or a ventouse machine, are these tools that you might use in your practice?
Absolutely, I don't. I'm fully trained and I've done many forceps and many ventouse deliveries in my life. When I switched over from the hospital setting to home birth, I don't even keep those instruments near me because the temptation then would be to start using them. If you have an obstructed labor and the mom can't push the baby out by herself, we call it and the mom gets transferred to hospital. Once you start intervening on a labor, so the same with induction. There's a lot of litigation going on at the moment with midwives that we're doing inductions with medication, and it goes pear-shaped, and it gives the whole profession a terrible name. It results in loss of life. So I personally, if the mom is not able to birth that baby naturally without intervention, we call it and we transfer. The same with, I think in the last 5 years that I've had my home birthing center, I've cut 2 episiotomies, which is a cut in the vaginal muscle to make the passage bigger for the baby. So if you're looking at physiological birth, position the mom, you put on your patient's socks, and you wait. And if the mum's going to birth, she'll birth. If there is something obstructing, it's better to manage that in a hospital setting.
For anyone who got confused by some of the terminology we use there, forceps and ventuse are assistive devices. A ventouse is kind of like a big vacuum cleaner.
Yeah. So forceps, you'll see them often on pictures. They look like big salad spoons. And they fit round the baby's head, sometimes just to rotate the baby or to actually assist the baby out. And then a ventouse, at the moment, they've got a device called a Kiwi, which is a handheld device. It's not attached to that big suction bottle. It's a handheld device. It's a magnificent device, but for use where you have a pediatrician immediately, where you have a neonatal ICU immediately, because things go pear-shaped. And so I don't take that chance. I keep it. If the mum can't birth, she gets referred. And my cesarean section rate at the moment is 4.9%. The World Health Organization recommends between 10 and 15%. So, sometimes I think maybe I'm a bit too patient, but if they're going to birth, they're going to birth.
Either you're a patient or they're a patient.
Exactly.
Jenny, you mentioned the maternal guidelines quite a lot. So obviously you adhere to legislation and stuff. And that actually prompted another question, which is, can you administer any medication or prescribe any medication? And if so, to what extent can you do that as a midwife?
Okay, as a midwife, we do have certain drugs that are in the maternal guidelines that we do keep for emergencies. So obviously I can put up a drip. If I've got a patient that's bleeding, there is medication that I give. But basically you need to get a prescription if you're going to use any opioids like pethidine or morphine. We go 100% non-medicated birth because obviously as science tells you on the table, every action has an opposite reaction, not always equal, sometimes catastrophic. So if you start administering opioids to the mom, you sit with sometimes respiratory depression in the baby, and it escalates. So we use natural methods of pain control, but obviously all the drugs that would be on an emergency trolley in a maternity ward, I keep in stock. So if I've got a bleeding mom, I've got gelfusion and drips and medication to stop the bleeding and to keep the mom resuscitated while we wait for an ambulance.
Do you use any medication that suppresses pain? I mean, if you say all natural, does that include like no pain medication?
100%. So we use positioning, we use water, we use birthing balls. If you empower a mom and you get her to get out of her head and into her body and to go with the flow, 100% of all the births I've done at my birthing center are unmedicated. So it's the support system, it's the education, it's giving the mom confidence. That's where my doula comes in so vitally important. They do massage, we do birth ball techniques, we do a mindfulness. So, yep, I'm very proud to say my moms deliver without pain medication.
Dare I say there's method to the madness?
Oh, 100%. I would rather a mom screams the place down if she needs to and roars her baby out than having a baby who doesn't scream when it's born.
And we have obviously covered this topic a little bit earlier in the day, but can you just clarify for us what is the preferred method of delivery and what is the recommended or medically recommended method of delivery?
You're talking to a midwife, so I'm of the opinion that anything that is not a high risk, every mom should be given that opportunity to birth naturally. Be it in a hospital setting where they do have pain relief, you've got the option of epidural or medical gas called Entonox or opioids. So if the mom just says, I cannot do this pain thing, I need something to help me along, they can still birth naturally with pain medication. So there's a lot of coaching before the time from my side and from the doula side about managing the pain.
So just to clarify, you still feel the preferred and medically recommended method of delivery would be natural or normal vaginal delivery?
100%. As I mentioned earlier, the recommended cesarean section rate is 10 to 15%. We're mammals. Mammals birth. So we should try and get our stats to 10 to 15%. Unfortunately, the statistics in the private sector for cesarean section is between 75% in some institutions to 90% in others. And in the state-run facilities, the cesarean section rate is between 26 and 27%. So both government and private institutions, it's way out of whack.
That's such a stark difference. I never realized it's that big. And
it's horrendous.
And you said that I think, is that specific for midwives, where the WHO or the World Health Organization recommends a cesarean section rate of 15%, and in your practice, it's about 4.9%.
Yeah. So no, World Health Organization states between 10 and 15% across the board.
Okay.
So that is, so that's worldwide. I think at the moment, the only country obtaining those levels is the Netherlands. In the Netherlands, everybody births at home with a midwife, except your high-risk patients. Then they either birth with midwives in a hospital, or as last resort, they go through the obstetricians for cesarean section. I stand under correction, but I think at the moment the only country is the Netherlands that actually falls within the WHO recommendations.
Maybe
we will double check on those stats for you and put them into the show notes.
Yeah, so the stats for natural birth and for cesarean section in South Africa at the moment, that's up to date. We got those stats at the seminar this week.
Maybe we can look at some of the benefits of the two different delivery methods, benefits and risks. So if we can start at normal vaginal delivery, or as you call it, natural vaginal births, what are the risks and benefits of those compared to cesarean and vice versa?
Okay, so for natural birth, and now I'm talking from a midwife's point of view. So a patient or a mom decides that she wants to give natural birth. She comes to a midwife. Most of the reasons that they will seek out a midwife birth, number one is cost factor. But I don't like to be told that I'm cheap. I'm easy, but I'm not cheap. But it is as a cost factor, birthing with a midwife in a home birth center is between 14 and 25,000 for a home birth with a midwife. Cesarean section is about 90, anywhere between about 75,000 and 90,000 in a hospital. But besides that, the more important reasons are that the mom gets personalized care. and it's continuation of care. So we build up a interpersonal relationship. We reduce the interventions. So there's a much better outcome for the mom and the baby. We look at the mom holistically, the family holistically. So their birth preparation and their breastfeeding and their postpartum recovery, we guide totally towards empowering that mom to birth. With a midwife, there's a lot more support and guidance. My patients know that, my moms know that I'm on call 24/7. It is exhausting at times, but I also have a WhatsApp group. So if I can't personally answer them 24 hours a day, we encourage other moms that have birthed or that are about to birth to support each other. So it's a very, supportive community. If you're birthing with a midwife, they get access to the home birth situation. They're improved, and this is evidence-based, they're improved maternal and newborn outcomes. So a baby that is born vaginally builds up a microbiome with the mom very quickly. There's skin to skin immediately. The mom's natural hormones kick in, oxytocin, which facilitates breastfeeding, kicks in quickly. So that reduces the risk of postpartum hemorrhage. It establishes the breastfeeding, which obviously is one of the guidelines that we would like to improve on, is the number of breastfed babies. There's also increased control over the care. So especially with a home birth or an independent midwife, there's continuation of care. They know exactly what they're in for. Yeah, we build up a relationship that lasts generations. I'm at the moment doing second degree birth. So the mom birthed with me, and now the baby that I helped birth 20 years ago is birthing with me as well. So I've just got to stick it out for another couple of years, and we'll be doing third, fourth generation.
I'm sure that'll be pretty special.
It is pretty special. It really is. You do really, it's you build up a relationship second to none with that family.
I think that's something some mothers also really appreciate. It's just that personal touch. It's not just book you in at the clinic, you birth, you go home, and then not that it's necessarily the case, but then you're left to your own devices. I think it's just purely the demands of the profession, where obstetricians don't always have the time, or because they're overstretched because of the healthcare system, and then they can't be providing postpartum support.
And what happens as well, there's a lot of disappointment if a mom books to have a normal vaginal delivery with the obstetrician. Often at 36 weeks, they start looking for reasons to Caesar the mom, be it real or imagined. So then they immediately go out of that mindset of having a natural birth. Okay, we're doing your cesarean section at 38 weeks. Book yourself in because the placenta is calcified, or the amniotic fluid is too little, or the baby is not in the right position. So it disempowers the mom. Immediately there is a negative effect on how that mom bonds with the baby, how she breastfeeds, her recovery. I'm not knocking obstetricians. My obstetricians are my most valued resource at times. But it's well known that an obstetrician will say to a patient, I don't do NVDs, I will be Caesaring you. Yeah, so a midwife does play a very integral role, especially private midwives. When you, I'm not knocking my colleagues either that work in the hospital setting, because those midwives work under tremendous stress. They don't know the mom's coming in. They have to very quickly build a bond. and trust with the client. And the mom has to trust the person that's looking after her. So, yeah, there's a lot to be said for being a private practitioner.
Can we touch on some of the benefits and risks of the cesarean as well? Are you comfortable speaking about that?
100%. So the biggest benefit for a Caesar is when you've got a fetal distress or when you've got a mom that's got eclampsia and is fitting, cesarean section is the only way to get that baby out. We need that baby out ASAP because we need to save the mom as well. So they are life-saving for certain conditions. Placenta previa, where the placenta is lying in front of the baby and the mom starts to bleed, or where the placenta separates from the wall and the mom is bleeding, and it will either cost her life, but obviously the baby first, but then her life as well. So we need to save moms and babies. The benefit of a Caesar is there's less, obviously there's no perineal. That's the area between the vagina and the anus. There's no trauma there. So at the end of the day, there's not too much difference between bladder incontinence between moms that had Caesars and vaginal births later in life. But a perineal trauma can lead to incontinence for a mom. So sometimes with a cesarean section, if it's necessary, you reduce that risk. In our busy lifestyle, a Caesar can be planned to the hour, minute, day. So a lot of moms need that. They've only got 4 weeks maternity leave. They want that baby out and they have a Caesar. The risks, though, of cesarean section are very high. You have the risk of infection. It's major surgery. You have the risk of blood clots developing in the legs, the lungs, the cardiovascular system after birth. The blood loss with cesarean section is, so you can estimate a mom to lose about up to 500 milliliters of blood with a normal birth. With a cesarean section, it's way higher, sometimes up to 1.5 liters of blood loss. There's also a risk of damaging the other organs surrounding the uterus when they cut through the abdomen. Sometimes they cut the bladder or they cut the ureters, and that leads to sepsis and all sorts of problems afterwards. And then there's obviously a longer recovery period, and the mom needs to get over major abdominal surgery and look after her baby, which can be debilitating. But also, babies that are born via cesarean section don't have that cortisol trigger that puts them into labor. We're talking now emergency cesarean where they haven't, or elective cesarean where the mom hasn't been in labor. The cortisol secretion from the baby prepares the body for labor. It's like an orchestra. Where they don't have that, we have a lot. It's called transient tachypnea of the newborn, which means fast respiration. That baby wasn't prepared to come out and breathe. The placenta's been breathing for the baby all along. And suddenly they come out and those lungs aren't 100% ready for breathing. The surfactant hasn't been secreted. And a lot of those babies end up in the NICU, in an incubator. And then also, once you've had a cesarean section, we were doing VBACs at home. Unfortunately, the legislation has changed. So a VBAC is a vaginal birth after Caesar. So unless you can find a gynecologist who's prepared to support your vaginal birth after you've had a Caesar, or a midwife working in a hospital, a private midwife working in a hospital, chances are you're going to end up with a second Caesar, or otherwise you can suffer with decreased fertility. Also, there's an epigenetic propensity to babies born by a cesarean section to later in life develop diabetes. So we're looking short-term effects, medium-term effects, and way long-term effects.
That's very interesting information. And some of the things that I've heard, I don't know, in my life is that, yeah, there's the lower risk with babies who are delivered vaginally, that the delivery method just helps clear the fluid from the baby's lungs. And also, as you've alluded to, the baby being colonized by the mother's microbiome, both the vaginal and gut flora, and that just bodes well for a stronger immune system, and it just primes that baby's immune system for early in life and whatever
Oh,
exposures
100.
they'll get. Because I suppose that's the natural process. We've evolved to go that route, but we
Yeah.
understand with all the complications of life that it's not always possible.
Yeah, and a misinformation. But there is nothing more rewarding than watching a baby emerge from a vagina, be put skin to skin with the mom, to crawl to the breast, to have delayed cord clamping, because we do delayed cord clamping. So the baby gets all that extra iron. It decreases the amount of anemia in babies. They get the stem cells. It builds up the immune system. Whereas with a cesarean section, there's very, very seldom, unless the hospital is rigged out to do a gentle cesarean. Pretty much it's immediate clamp and cut the cord. Baby gets whisked away onto a warmer, gets prodded and poked and suctioned, which is the bane of my existence. Gets suctioned and prodded and poked and whatever, and it's traumatizing.
Thank you for sharing that with us.
I'm not Caesar shaming anybody. Nobody must feel that their body has failed them if they do end up with a cesarean section.
Yeah.
That's not the object of the thing, because there is a time and a place for a cesarean section. And many times I've said, thank heavens for the obstetrician. If it wasn't for the obstetrician, we wouldn't have had a good outcome. But it's not to be taken lightly.
Yes, definitely. And thank you for speaking from your perspective. I think the episode and the information also need to be listened to and digested in context of you being a midwife. Maybe you could also shed some light on the average pricing on the two methods. I think you've kind of alluded to that.
Yeah. So that's why I say we get told, I want to come and see a midwife because you're cheaper. So pricing, mums have a horrible fear of a government hospital because there are horror stories. So they decide they want to rather go privately. If you're having a vaginal birth in a hospital, you're looking at around 45 to 50,000, including the gynecologist and the pediatrician's fees. That's sort of ballpark figure. That's all supposing that everything goes hunky-dory and the baby doesn't end up in the NICU. Then you're looking at it's so exorbitantly expensive. With a cesarean section, anywhere, depending on who the obstetrician is, and because obstetricians can pretty much charge whatever they want, you're looking at between 60 and 90,000. For a home birth or a midwife with a birthing center or a home birth, the prices range, depending on area, obviously, between about 14,000 to about average 22. So there's a huge financial implication as well.
And in a practical sense, money is very important. We all know that. It's unfortunately one of the things we do need to consider. So I still feel our listeners will benefit from the candidness of what the industry standards are in terms of pricing, as much as it might be very whimsical to pick your birthing method of choice. One still needs to be practical when it comes to financials. So we appreciate that information.
Yeah, you have to, because the costs don't stop the minute the birth is over. That's when the costs actually start. Having a baby is not a cheap exercise.
Absolutely. I think anyone can attest to that. Right, so we are coming towards the end of our technical questions. It is a very, very difficult topic that we are going to now cover next. It's going to be really short and sweet because no one's really sure of what's happening. But we want to just touch base a little bit on the National Health Insurance Act that is very likely going to come into play. We would just like to know, in terms of the NHI, do you think there's going to be anything affected in your profession by this change in structure in the medical system, whether it be in terms of your insurance or the rates of natural deliveries versus cesarean sections? Do you foresee any major changes in your field?
From my perspective, it is so difficult to predict exactly how it's going to play out. From what I understand, they want everybody to register as a service provider. They will name the price and they will pay the service providers through the NHI fund. But then we've got the major problem of how is stock going to be procured? How is the money going to be allocated for medical malpractice? Because if they are calling the shots, then basically you pretty much will have to go under the umbrella of a national health insurance malpractice scheme. So to be quite honest with you, it's a case of what a midwife does best is wait and see. I honestly cannot give you sort of evidence-based answers on the NHI. So it's a worry for all of us.
That makes sense. I mean, it's understandable. It's nothing's been finalized yet, and nothing is yet to be implemented. So I think it's probably unknown territory for everybody. And as you rightly say, it's just going to be a waiting game. And luckily, you have mentioned that it's your one of your strengths. You as a midwife is to be patient. So let's see how it pans out over time.
Yeah,
Maybe
there are things going to court in the near future because there are pieces of legislation in the acts that just don't line up. You can either do one thing or you can do the other, but you can't do both of them together. So it's going to court. There will be court cases, and the Board of Healthcare Funders and all the role players are involved. So it's pretty much I think, a case at the moment of wait and see.
Alrighty, so on to something a bit more fun. So we've thought
Mm.
of closing off with two or so questions. One question being, what is the most surprising thing you've learned about the human body during labor and delivery?
The most surprise, this is across my whole career as a midwife. I think the most amazing thing is that a human being can grow another human being, grow an extra organ that functions independently of everything else. And then when the organ is no longer needed, we're talking about the placenta now, that they can just get rid of that organ. I think that's probably the most amazing thing about the human body. And also that such a huge head can come out of such a tiny, teeny weeny little hole that the body can stretch so much.
I think that's the scary part for most people.
Yeah, the ring of fire.
Okay, so we have a tiny little section that we're trying to bring into all our episodes, which we call the fake news section. So if you can tell us what is the most common misconception about midwifery that you would like to debunk?
I've been called everything from, and I'm going to use the Afrikaans term. I'm not sure if you've got Afrikaans listeners, but I've been called everything from a voetvrouw, which I guess we do because we do promote breastfeeding, to a fruitelvrouw. So we're not a voetvrouw, we're not a fruitelvrouw, we're a fruitvrouw, a midwife, which means with women, not abusing women.
Yeah, so just for the listeners, the non-Afrikaans listeners, that's like either a woman who
a
feeds,
feeding
woman.
wife,
Yeah,
a feeding wife, or
A fiddling
wife.
Yes, a fiddling
Snap.
wife. So I would not like to be known as the fiddling wife. I rather keep my hands to myself as much as possible.
And with that, I think we're going to bring you to a close on a lighter note. Jenni, I'd just like to thank you so much for coming on to the podcast today and sharing your experience. I mean, it's really, as a man, just special for me to hear with how much passion you speak and experience. And when you described the benefits of a normal vaginal delivery and the baby being born out of the mother and just that skin to skin contact and the feeding, the initial feeding, it was really endearing to hear how often you get to observe and witness that. So thank you so much for sharing all the intimate details and the little anecdotes, the facts, and also the punny jokes. We really found that quite entertaining. And once again, thank you so much for your time. I hope you also had some fun and that you also enjoyed actually sharing your knowledge and experience, because I mean, I can't see how it can be any other way.
Oh, it was really awesome chatting to you guys. I loved it. And yeah, you're correct. I am very passionate about my profession. And I hope one day when you're going to be a dad, if you're going to be a dad, you find your way to a midwife.
Thank you so much, Jenni. So if anyone has got some questions for Sister Jenni, we will have a platform available on the website where we will take your questions, we will bring them to her attention, and we will try to answer them in one of our Q&A episodes that will be coming up later in the series. So for anyone who would like some of Sister Jenni's practice details, we will make sure that they are up in the show notes for you. We are also going to include the Sensitive Midwifery forum information, where you will be able to search midwives in your area as well as doulas, or just to get some general midwifery birthing information from that document. So for anyone who is interested, we will make that available to you. And we would just like to say thank you so much for tuning in to another episode of Science on the Table.